Okay, I think that we can start. Good afternoon, everyone. I hope you don't get too sleepy after lunch. Thank you very much for staying here. It's an honor and a privilege to welcome you to this symposium titled Contextual and Higher Education Challenge in the Field of Harm Reduction, organized by ISAP and ICU-DDR. Thank you very much, especially to ICU-DDR for the possibility to organize this symposium. Today we gather to explore a topic of vital importance, is harm reduction in the context of drug consumption. This symposium aims to provide a comprehensive and relevant insight into drug-related harm reduction, emphasizing the crucial role that universities play in this field. Today we have 3 speakers and we have a lot of time, so if you want to discuss after our presentation, we will have a lot of time to speak and to discuss about the contents of the presentations. So I will present our participants. First of all, the first participant is Dr. Xavier Ferrer of the University of Barcelona in Spain. Dr. Ferrer is a clinical psychology specialist and health promotion expert with over 4 decades of experience in addiction research and training. As the director of the postgraduate master's degree on drug dependence at the University of Barcelona for 37 years, he has graduated over 700 professionals from 17 countries. Dr. Ferrer also serves as the executive director of Fundació Salut i Comunitat, Community and Health Foundation, is a Spanish NGO employing 1,600 professionals in 130 centers, including 36 dedicated to addiction services. His extensive contributions span the design of addiction treatment centers, involvement in various settings, and the coordination of European projects on drug demand reduction. He's a member of the board on ICU-DDR2. And currently, his research focuses on drug treatment, evaluation of the intersection of addictions with another situation like homelessness and interpersonal violence. Our second participant is Dr. Roberto Perez Gayo. He's a member and coordinator of Correlation, the European Harm Reduction Networks in Netherlands. Dr. Perez Gayo is a researcher, university teacher, and social designer working in the fields of harm reduction, public health, social justice, and innovation. Currently, they serve as the head of policy of Correlation, this European harm reduction network. From this position, they function as coordinator of the European Network of Drug Consumption Rooms, core group members of the Civil Society Forum on HIV, hepatitis, and tuberculosis, and contribute as an expert to thematic groups at EMCDDA, European Center for Disease Prevention and Control, or the World Health Organization. And finally, our third participant is Dr. Jallal Toufiq. He's a professor of psychiatry at the Rabat Faculty of Medicine in the University Mohammed V in Morocco. He's president of the United Nations International Narcotic Control Board of Vienna, Austria. He's professor of psychiatry at the Faculty of Medicine and Pharmacy of Rabat in Morocco too. He's director of the Arazi University Psychiatric Hospital of Sale, Morocco. Director of the Moroccan Observatory on Drugs and Addiction, and member of the Moroccan National Commission on Drugs Board, and member of the UICDDR. So we can start with speaking of Xavier Ferrer.
Okay, thank you. ¿Ayudo a posarlo? No sé si tiene un pointer. Thank you very much for the presentation. Hello to you all. Then I have been required to carry out a kind of, say, framework presentation. about harm reduction, and also to elaborate a little bit about how universities should be involved in teaching about this issue. Then first I tried to develop a more conceptual approach to drug-related harm reduction. So I will speak very much about concepts, about words. So I prefer even to write, because to focus on these words, because words here are important, have meaning, and should be distinguished some words from another ones. Then, first of all, I would like to underline that harm reduction has a difficult conceptual approach. This is not only harm reduction, but on the field of drugs, concepts about drug issues are imprecise, will change with time or with context, are influenced by societal and personal options, and the languages may influence them. It's not the same if we speak English, or es no lo mismo en español, ce n'est pas le même en français. So the concept will change. It's not the same. The translation is not exact. Then progress in clarification and managing this complexity is needed. Then let's see first, are we speaking about harm reduction? So which harm are we speaking about? Are we speaking about a pre-existing harm that should be then reduced? Okay, if the harm is already existing, we may reduce it. But what happens is if this harm is still not existing? Then should we speak about reduction, or maybe should we speak if this is a new prospective harm, which is not to be reduced at the individual level, but we have to avoid it to happen? Then it's not so much harm reduction, maybe harm prevention. But maybe another possibility to look at it, maybe to think not at the individual level, but at the global level. May we think that even, for instance, avoiding a single new case of, for instance, HIV transmission, we are contributing to reduce the harm of HIV at the global level, not for this person who still hasn't got infected, but at the global level. So that's a first conceptual thinking. In some of these cases, in fact, we were not reducing harm, but we're reducing risk. Harm and risk, in fact, are strongly connected, and in this field, sometimes they may use interchangeably. Conceptual is not the same, because risk may precede harm, should precede harm. But as I was telling to you, sometimes these concepts are used on a quite, you can change one by another. In fact, in some languages, as in French, for instance, they are not speaking about harm reduction, but about risk reduction, réduction de risque, and the meaning is the same. For instance, in Spanish, we make sometimes a distinction between harm reduction, which is more applied to the harm you try to avoid in care settings, as outpatient centers or methadone, and risk reduction that we use, for instance, to reduce risks in nightlife scene. For instance, can we think on rape parties, on young people abusing synthetic drugs or whatever. In damage, problems are also used. In fact, I was remembering the first seminar we organized within the master's degree on addictions I am directing was in 1987. And in 1987, we already included this, but we were calling it preventing drug-related problems, not drug-related harm, okay? But the content was the same. Well, on the one hand, you can think on three distinct strategies, and you can compare demand reduction with supply reduction and with harm reduction. Okay, that's one way to look at this issue. In this case, harm reduction could be considered as different because the underlying idea is that reducing harm is not only to be achieved through reducing demand, but through, say, modulating this demand. For instance, someone will consume the same amount of alcohol in a day or in a week, but not before driving. Or will inject the same amount of heroin, but no with a syringe shared with 10 people more. So we are not reducing the demand, but modulating the modality of use. Reducing supply, theoretically, should also imply reduce the harm, but it depends. It depends how you try to reduce the supply. You can do it through dangerous strategies that, in fact, may backfire and do more harm than good. Well, this is one way to look at it. So you compare harm reduction with supply reduction and with demand reduction. Okay? Let's look at it otherwise. Let's compare treatment with prevention and with harm reduction. For instance, if you look at the title of this conference, you will see in the title of this conference, we speak about treatment, recovery, prevention, and harm reduction. That's a way to look at this. For instance, in Spain, we would not differentiate treatment from recovery. For us, recovery is a part of that we call globally treatment. It's one of the steps of treatment. It depends. Provided we understand each other and clear operational definitions are made, there is not any absolute truth. This is important. But well, in any case, we can understand harm reduction as different from treatment and different from prevention. Why? On the one hand, treatment is aimed to recover from an illness or a disorder, if you prefer, following the WHO definition of mental disorders. We are speaking about drug dependence as a mental disorder. Okay, then treatment is after the fact, and prevention is before the fact. And what about harm reduction? Well, harm reduction is maybe compatible with both of them. And I will try to say to you why I think that this differentiation is not the best one. Because on the one hand, treatment. What if the best option for treatment is to keep ongoing a dependence, for instance, to methadone? Because we judge this is the best available option. So in fact, we keep alive a dependence, but still may be the best possible option. But you can also understand this action as a way of harm reduction. It's possible. So in this case, we may have an overlapping between the concept of treatment and the concept of harm reduction. And let's now see about, let's look about prevention, okay? Prevention, if we have a very, very restrictive understanding of prevention, and prevention, we understand that prevention means avoid any drug use or avoid any drug dependence. Okay, if we do that, we can differentiate. But if we adopt a more wide understanding of prevention, you will see this is not so easy. Because harm reduction mostly, not exclusively, because it also overlaps with treatment, but from our point of view, may be considered as part of our prevention activities. I will tell you why. Let's look at the definition of prevention. Let's look at the dictionary. What's prevention? Prevention means to avoid an unwanted event judged as harmful from occurring. You can apply this to everything, to traffic accidents, to be robbed. Okay, but the use of drugs may facilitate many harmful and unwanted events to occur, especially when the drug use is repeated, not only. Among them, death, overdose, social exclusion, dependence, family troubles, accidents, crime, related illnesses. So these are harms related to drug use that you can avoid, then avoid an unwanted harm to occur. That's prevention. Okay, so then the dependence itself has a special position into this list because it's a harm in itself. Dependence is a harm arising from the drug use, but at the same time, because the repeated use may further facilitate the occurrence of many other harms. So I would suggest as definition, not perfect, that harm reduction may be mostly defined as prevention of unwanted results of drug use other than addiction itself. So even if drug use and dependence continues, we are wanting to prevent early death, infectious diseases, overdose, family troubles, accidents, social exclusion, thefts, homicides. Okay, I was speaking about concepts, and I would like as well to link concepts and values, because when speaking about harm reduction, I would like to reflect on values as well. So we may also think on harm reduction as a kind of common framework where treatment and prevention and all policy-related, drug-related policy should be included as to be legitimated. Because why we do treatment? To avoid harm. Why we are carrying out prevention? To avoid harm. What supposedly is drug policy in a country or worldwide? To avoid harm. So theoretically, it could be think as everything included into harm reduction. Because if we are not going to reduce harm, why to do it? It's I don't know. It's a personal moral choice. Is this acceptable? Then the focus. Then we have to change the focus. It's not on drug use, yes or not. The focus has to be changed to harm related to use, because maybe it could sound heretic still for someone, but drug use is certainly a risk for the occurrence of drug-related harm, but there can be acceptable uses, even positive uses. For instance, a social use, obviously within a non-harm reducing level, not harm producing level, I'm sorry. An appropriate medical use is not to be avoided, certainly. A religious or ceremonial use, a recreational use where the same need for balancing the wished effects and the risks do apply. Then in this case, yes, any use, especially too early use, and even more so with some substances in particular, is a risk for a later harm. But which a behavior is a risk for later harm, it's also happening with driving, traveling, doing sports. That's a thought I had sometimes. What about climbing or car racing? Is taking a very important risk in exchange of which kind of personal rewarding or societal gain? I don't know. Is this heroic, but drug use is to be blamed? So it's just, I think we are in a country that invented philosophy. So I think we have to have our brains working. And that's very important to think on this. So if you allow me to do a small joke, which is not mine, but from a French writer, André Malraux, he was saying, life is risky. Nobody comes out of it alive. Okay, so we are confronted to managing risks and pleasures, and that's life. And pain and hope, that's life. So, are we legitimated to propose to avoid all these behaviors because of the risk? So it has to be everything forbidden. So there is risk from traffic accidents. That's forbidden to drive a car. You have to be walking or maybe in public transport. If those companies producing cars will be closed down and car sellers will be jailed. Okay, for sure it will work to reduce a lot of traffic accidents. But maybe we have to balance risks, we have to balance wishes of the population and the real possibilities for some of these actions really to succeed. Then, speaking about values, so every action or policy or program should be legitimated by being aimed to decrease a well-defined drug-related harms, should be feasible by having the means needed and maximum acceptance from the target group involved. As much as possible, you have to go against the people's wishes. Has to be based in a carefully considered balance of wanted and unwanted side effects. This is done in medicine. It's not so often done in policy to take into account this balance of wanted and unwanted or side effects. And has to be the most intelligent or cost-effective action based in evidence. And so, being in this country, in Greece, the main cradle of the scientific and the values that humanity is sharing today, let me propose, as especially opportune as our guiding values for harm reduction, and maybe for all drug-related actions, why not? Let us propose respect and care for human life. So the first is not to avoid drug use at any price, but first is respect and care for human life. This was taught by a Greek ancestor, Hippocrates, whose Hippocratic oath is still the basis for the physician's oath around most of the globe. And not only life, but promotion of the best possible, that's an important concept, quality of life for everyone. Let's also call to respect for the individual freedom, as taught by Socrates, who also shouted, that's important, that true liberty is based in knowledge and wisdom. So, being the ignorance a type of slavery. So, to make a really free decision, you need knowledge, good information, for instance, in this case. And finally, last but not least, solidarity. Solidarity with those using, say, support and punish, but also solidarity with those not using drugs that may be affected from the consumption of the former ones. This implies support and care also not only to the drug addicts, but also for the whole community, avoiding drug-related crimes, gender violence, violence against children, accidents, and certainly respecting the health and the rights of those who are unwillingly consuming drugs, as passive smokers, or what about the fetus receiving alcohol or other substances or nicotine during pregnancy? So that's also harm reduction. So here again, let me quote a wise man born very near of here, just around the corner, 90 kilometers away, Aristotle, near the main square in the city, has his name, Aristotelus Square, that taught us very important things. Anthropos in politikon son physei, which in my bad Greek means that the man is a social animal by nature, which means that mutual care and support is essential for us and consubstantial with human essence. Okay, then, which harms should we target? I wanted here to make a small consideration, because on the one hand, we have to target harm to physical health. Okay, yeah, we have to decrease the use-associated risk, the syringe we were mentioning, prevent illnesses, and early detect and diagnose them. Also important to know if someone has an illness, has to know it to avoid to spread it to others, okay? Also to promote healthy behaviors. We may be willing to reduce harm to mental health. Many drugs will either increase previous mental disorders or create new ones. So that's important to take into account this. There is a harm to the social inclusion of the drug user. Drug use, alcohol or other drugs may lead to, problems of housing, loss of income, social isolation. So increasing better living conditions, appropriate housing. So all these, even avoid an imprisonment, because entering the justice prison system may be usually a harm on itself. Sometimes it could be different and can save the life of someone, but it's more the exception than the rule. Okay. Then I would like to also to speak about the harm to the third parties, the family and the community. I was mentioning it again before, sorry. And then just let me stress on three particular harms that, from my point of view, are underestimated and should be more taken into account when thinking on harm reduction. The first one, related to mental health, is suicide, which is related to mental health and will produce its fatal result in physical health. That's death. Okay. Then the second one I would like to underline is homelessness. Homelessness is a very significant type of harm on itself, which should be really combated. And the third one is, for instance, the alcohol fetal syndrome as a relevant underestimated harm. Going a little bit more ahead on this conceptual approach, we are now working on a system for evaluating harm reduction. And to do that, we needed to, first of all, to use the so-called logical framework analysis. And so, arising from an objective, for instance, the first, reduced harm to physical harm, highlighted in yellow, you can go to see you can divide this goal into more specific objectives, okay, as the positive, and also have indicators to see whether this objective is attained or not. This objective, you may divide it into more sub-objectives, and then finally, this is the result, a kind of, a kind of table, a kind of cross table. We have like 16 of these with the different objectives, sub-objectives, indicators, actions, also indicators for the fulfillment of the different actions that should lead to attained objectives. Okay, we are now working in a proposal for a kind of system we may share with other parties interested in the future. Hopefully, I can inform you about this in future conferences. And so now only some short words about the last part of my intervention, which is related about training within a master on addictions, which is our experience. Okay. First, this is our responsibility as universities, train the future professionals in an open-minded harm reduction perspective, and to consider these principles and the values I was speaking with you, and discuss them. So then we have to work on treatment, on prevention, but also on harm reduction. They need to accept that individuals may be not able or not willing to quit drugs. We have to open with these students an open, careful, and respectful debate. For instance, we do a compulsory, mandatory 50 hours initial training on harm reduction for everyone, all students, regardless they are physicians, psychologists, social workers, go through the same. Then on they have 2 years training. On the first year, all of them go through short visits or short placements, say 1 day or two, to methadone programs, civic exchange, family violence prevention programs, overdose prevention, drug testing and information and night parties, harm reduction within the prison, drug consumption rooms. We have 12 of these drug consumption rooms in my region in Spain, outreach street programs, and also social exclusion programs. As for instance, we have some drop-in for people who is still using drugs in an active way, or housing first. Okay, and then, and in 2 minutes, in the second year, they can choose a placement within a single institution. On the first year, everyone does small visits, short visits. not only to harm reduction. I only mentioned harm reduction, but they go also to therapeutic communities, to drug-free programs, to prevention in a school, okay, everything. Then, in the second year, they can choose a specific place to stay for 300 hours. So maybe they can choose to be only in a drug consumption room or in a specific family violence prevention program. And they are obliged, as in everything everywhere in Europe, to do a master thesis, and they can choose as well to carry out this master thesis on this subject. And there is finally an optional seminar to deepen into harm reduction, 3 credits, which is equivalent to 75 hours. So, what after our experience, and I will finish with this, I think it's important to be determined to do this training despite difficulties, despite resistance. From 1987, it has been included in the curriculum, but at the beginning we were very criticized. We were not strong enough against drugs. We are not strict exactly against drugs. We are for the people, which is a little bit different. But you are not against drugs. Sorry, maybe if I need morphine when I am when I am ill from cancer, please, I hope any fanatic will forbid this. Okay, then is to be pointed out that almost all our former critics are today strong supporters, and we have to face the issue with the students. It can be conflicting. Some of them maybe may have been affected by some kind of drug problem themselves or their family. Others are on the contrary side, are thinking that drugs is everything is happiness, and have an, say, anthropological naive conception of drugs. We have to, and it's important to merge both mentalities. Okay. And so I think that's important to, sometimes we got some pressure not to speak on this topic, and I think we have to resist this pressure because university, I think, is the temple of the wisdom and must continue to be so. So thank you very much. And here you will find also our email to contact us should you be interested. Thank you again. Ευχαριστώ πολύ.
So thank you very much, Dr. Xavier Ferrer. It's a moment of Dr. Perez Gayo. Roberto.
Claro, vamos.
A ver. ¿Es este de aquí? Tenemos tiempo, ¿eh? A ver, ¿dónde estamos? Aquí. Somi.
Good. I think I may need to put it a bit higher and taller. Good afternoon. I would like to start. Thank you so much for the invitation to be able to come here and to share with you a tiny bit of the work that we do and to be able to reflect the invitation that it came to us. At the end of the day, we are a civil society working in the field of harm reduction to reflect a tiny bit on universities, and particularly the role that harm reduction has within universities, but also the cooperation between universities and the harm reduction field, staying in contact with the communities. Maybe briefly, just to give a bit of a context, for you to let you know, Correlation, the European Harm Reduction Network, is a center of expertise, a civil society organization that is working currently with around 350 members, out of which I think it's 320 NGOs. They are working in the WHO Europe. So a lot of the work that we're doing is basically being on the ground, being in direct contact with the communities, and just from there try to work a tiny bit in different fields. So in different priorities. One of them is to develop community-based and community-led research, and the idea is to try to complement and to fill gap for already existing research initiatives, but also monitoring centers and also other actions. Also, we do a lot of work on capacity building, and the idea is to try to support professionals in the field to be really able to develop the capacities, the skills, and the knowledge that might be finding difficult or challenging. So there is quite a bit of that I will be reflecting today. Another of the part that we're doing is networking. So for us, one of the things that is important is to create the infrastructures by which different stakeholders can come together. either academic or people working in research, policymakers, social and health professionals, community-based community organizations, communities themselves. So how do we bring this together? How do we create a dialogue and a cooperation? And the last one is advocacy or participation in policymaking processes. Today, what I would like to do is to share a tiny bit of a couple of key data that could contextualize a tiny bit and maybe give an orientation of the situation of harm reduction in Europe and the current needs and challenges when it comes in relationship to work with universities. And also at the same time, I would like to share with you 3 examples of cooperation with universities and civil society and communities that perhaps could inspire you to look not only into the type of curriculums, themes, and topics that could be included within the universities, but also the type of initiatives of what other role the universities can have when it comes to support and ensure the well-being and the human rights of people who use drugs. To this end, I'm going to be at the beginning working with these 2 publications that we have been recently launched that perhaps you could find interesting, and this is what I was mentioning based on our community-based and community-led research. The first one, the Central Harm Reduction Services, is a part of our monitoring system that we are doing at the moment with 35 cities in Europe. 1 NGO in each of these cities in every country provides data and information from the ground. And the idea is to have a bit more of a qualitative understanding of what is it that is happening in the communities and what is it that is happening also on the level of service provision. Because oftentimes we realize that on paper things are a particular thing, but in the moment that we look into a smaller scale from the level of the city, things get a little bit more different. And the second one is a publication that we just recently conducted with 65 NGOs in WHO Europe, trying to understand a tiny bit more what are the challenges, the barriers, and the work that is done on community-based and community-led organizations that they are trying to implement communicable diseases, care, and support for people who is injecting drugs. To give you an idea, currently in Europe, the diversity and the availability of services that you can see is already far beyond many of the things that actually sometimes we are understanding. As you can see, one of the things that for us was important to include in here, and I'm going to be building up a tiny bit on what Xavier was saying, is like, for example, the inclusion of legal support as a harm reduction service, also income generation, as you can see, also temporary housing. So at the moment, that already brings a bit of a different palette that make us understand that harm reduction is not only a set of strategies, health strategies for ensuring a lack of negative health outcomes for people who use drugs, but also to ensure the well-being in the broader sense and also the human rights of people who use drugs. Now, in here, there is a tiny detail that perhaps it takes your attention, because usually when we are speaking about harm reduction, one of the key interventions that we always see is opioid agonist treatment. And as you can see in here, the offering opioid agonist treatment is one that still is the lowest. When suddenly we have other ones, like compared, for example, with naloxone, needle syringe provision, other elements are much higher. In here there is... Okay, if you see at the end of the graph, the third from the end says opioid agonist treatment. Just right before heroin-assisted treatment and drug checking. This is very crucial for harm reductions, not only for ensuring the well-being of people who use drugs, because also is the primary prevention method for the transmission of communicable diseases. This reflects how in Europe this is unevenly distributed, and the fact that you're seeing that most of the services are relying on referral and linkage to the services is going to bring some of the problems that at the moment we are having in cooperating and in collaborating with other health professionals that are not working directly in community-based and community-led services. This is another element that for us becomes very important. In this study, what we wanted to see is the acceptability of services. One thing is like is the pointer in there? Ah, cute. So we go full shot. Okay, cool. Okay, let's do it this way. That was a good suggestion. Besides trying to understand what is the availability of the services and the accessibility, one of the things that for us is important is also like the acceptability of the services. And by acceptability, we try to see is like, okay, are they accessed by whom and how and why? And one of the things that you can see is that despite that OAT is one of the services that still remains underserved considering the need that exists, is one of the ones that actually is the most accepted. Could you have an idea of why? simple question, because it's a very interesting contrast. I will let you know in a tiny second. As you can see in here, we see that still many of the harm reduction services and many of the services that exist for people who use drugs are still facing some problems with accessibility. And this has to do with the way that some of the services and some of the professionals are able to respond to the diversity of the communities of people who use drugs. Whereas we see that in Europe, the majority of harm reduction services in the last decades have become really good at developing support, care, and health, particularly catering for a profile of user, which tends to be male, injecting, that oftentimes is experiencing homelessness. When it comes to other intersections that currently Europe actually is trying to deal with, problems start to arise. And in here, needs start to arise to be able to support and to provide to professionals with the formations, the skills, and the knowledge that they need at the moment. As you can see in here, when we are asking to all the organizations if they have the possibility to reach out, to establish contact, and to work, as I was mentioning, as you can see in here, injecting opioids in the majority of these cases is absolutely possible. But in the moment that we go more into here, we start to see that reaching out and engaging with youth remains still complicated and challenging. People who practice chemsex, people who are in prison settings, LGBTQ population, migrants with or without legal rights, party settings, migrants with legal rights. And this opens up a whole series that you will see in here. How, for example, the majority of the respondents, and this doesn't work anymore, yeah, it works. In the case in which that happens, in the majority, lack of specific knowledge happens with LGBTQ people who's using drugs, migrants who use drugs with no legal rights to assistance, and people who practice chemsex. There is many organizations that still they are putting forward that we need help with this. We don't know how to work with this. How do we do it? How do we engage? Another part that for us is important is not only how harm reductions at this point need a bit of support to be really able to implement services that take into account these intersections of marginalization, exclusion, and in many cases criminalization. Also sometimes what we see that is thank you, because I can be just Another of the problems that we are seeing is a frequent amount of stigma that happens not only when it comes to work with people who use drugs, but also with harm reduction services themselves. And this happens a lot with healthcare settings and other social services and the difficulties that they are experiencing in working with the centers. As you can see, the biggest reason that is argued is this one. And if we focus exclusively on communicable diseases, the main challenge is to be really able to provide these basic services of harm reduction, stigma-related, 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 stigma-related. So in here, it opens another big question that has to do with how come that these professionals, that they are really able to deliver services that community-based and community-led services are not able to do. And if also these services, if we move ourselves in other frameworks of decentralization, let's bring the services coming in here, let's work with community themselves, cooperation, as you can see, is not really possible. As you can see, this is a bit more of information of the cooperation that happens in here, the typology of cooperation that happens, and still the challenges in ensuring the cooperation has to do with the stigma regarding the history of drug use or minority status. Another important one has to do with health insurance, but that I'm not going to open that can of worms because we could be here discussing for a long time. More importantly, if you remember, I'm coming from this area of harm reduction, look in an intersectional way in which we can be looking into multiple factors, structural factors of vulnerability and harm. When it comes to the cooperation that I was mentioning, we see that actually it still keeps on being quite complicated, appears, cooperation with services focusing on aging people, also because mainly there is none. Public emergency healthcare still remains very challenging. Public social support services remains very challenging. Primary public healthcare remains challenging. So there is a big element in here to start questioning of like what kind of programs and what kind of cooperation we can be establishing so that these professionals are able to start to work and to cooperate with one another. So I will bring here 3 examples that I think it could inspire you. One of them, if you remember, there is this data that is coming that working with AIDS and drug users is complicated. There is a project that actually, that's how I got to meet Xavier and how I got to meet Fran back in 2000, 17, 16, 17. And the idea was to be working with people who use drugs who are already aging. At the moment, currently, we see that it's a group that is particularly vulnerable in relationship to not only multi-comorbidity of different mental health, physical decay after many years working around, but also because of the fact that when it comes to inpatient or even outpatient care, there is no tools, there is no resources to be really able to work with this. Also, to give you a tiny bit of an idea of the importance of this and the lack of specific services or even training or specific formation that exists, this is at the end, in the middle of last year, the MCDDA, in one of these mini guides about health and social responses, still was going back into the thread as one of the only examples that exists as a curriculum and as a way of training when it comes to aging drug users. The project is far too complex. I'm going to be letting you go and dive into it because there is a lot of interesting information. But what I want to bring your attention into is one of the outcomes, which was the training curriculum that was developed. Because one of the things that we were detecting, both the organizations that were working in the field, and in this case, we were working together with the University of Frankfurt, was that actually there was a training needed for professionals both in and outpatient services, in addiction, nursing, and medical care that have to challenge the specific issues that happen. So there's very few services that in the moment in Europe are able to do this. So for example, these are the topics that we're covering in this training that will be resonating with many of the things that actually you have been putting forward. This is still, for a lot of these professionals, I need to know more about substances, substance dependence, age-related diseases, multi-professional support planning, ethical principles, inclusion and integration, information, and all these elements. Another good example that you have in here, and I'm also very happy that you were mentioning about it, it was harm reduction for homelessness. Because in Europe, although at the moment, in very general terms, we can be saying that the effectiveness of harm reduction exists, has been proven, is not equally distributed. And also what we see that specifically in services that they are targeting people experiencing homelessness, there is a bit of a difficulty to approach or to implement strategies that are not abstinence-based. And this has a bit of a problem because we are speaking, as you can see, that housing exclusion is a structural factor that increases not only the risks, but the harms of people who use drugs. And in the moment that actually you are demanding that a person needs to be stopping substance use to be really able to access a vital life-saving services, what you are generating is that those who are more excluded are going to be in the highest increase of risk and harm. So what we did in here is trying to look into two different things. One, what are the professionals working in the sector of homelessness that normally they will notify themselves as harm reduction, and what are the knowledge and the skills that they need to have? And on the other hand, those who are already implementing harm reduction measures, what we noticed is that they were focusing very much on behaviors, but they were not really able to tackle the structural conditions that increase and condition the harm that people who use drugs are experiencing, and that they needed to understand a tiny bit better how oftentimes it was not that much about implementing specific measures, but about creating spaces, conditions that actually remove those, I lost track totally of the thought, sorry, of the harming principles. One of the things that we did in here, and you will see that it's still very much the same knowledge that within the homelessness professionals needed to have. Substance use and homelessness, harm reduction principles, particularly it was super important for us that people was able to understand the difference between a risk, between a harm, and between a vulnerability. Also the idea of specific harm reduction interventions for homelessness services, peer involvement, that's something that for us was very important. How do you work with that? Intersectional frameworks for service design and delivery, particularly the intersection of drug use, homelessness, and gender. What happens when you're a woman in public space that needs to be using drugs? What happens when you're a woman who uses drugs, who is on the street, that actually are criminalized because of your migratory status? How do you work with this complexity? And the last one, social justice frameworks and advocacy, how services and also how universities, they can become advocates within policy change and policy transformation. More slow? Oh, wow. I'll try to be even more slow. For going slower, I'll continue trying. Those who know me know that I can go even quicker. Last element in here, we're being in the area of migration. While we know that there is several risk factors that are increasing the vulnerability of new group of migrants, such as traumatic experiences, disengagement with society, unemployment, poverty, we see that services and municipalities around Europe are faced with the urgent challenge to address these migrant needs. Now, what we are also noticing that when it comes to information about this is completely non-existent. And this is for us something that was another beautiful collaboration or cooperation that we did. It was with 4 organizations in Athens, France, in Paris, in they will pop up later, all of them. And we were like doing it together with the University of Ghent, and also IS Global in Barcelona was participating, and Fixpunt in Berlin, and I think that's it. And then one in the Netherlands, Amsterdam. And one of the things that for us was important, first of all, to have a bit of an overview of what exists, and for that it was very important to be working with the university, and this is one of the things that for us civil society is important, is the technical support that sometimes we do not have, and also the access to resources like information that we do not have, to be really able to understand what does it exist, and to confirm there is no information about this, and then from there to be really able to develop a consensus-based study in which different stakeholders can be putting forward what is the understanding, what is it that is observed coming in here. The second part, and this is something that was very important for us, is to develop participatory research methods that actually put people who use drugs themselves and migrants themselves at the center as the experts on the topic. And this a lot has to do with oftentimes when we are doing this work, it's just very embodied, it's very tacit knowledge, the one that we have not only about the institutions we are engaged in, but substance use itself. It's a very specific type of knowledge that we need to understand. So what we did in here is to set up 4 research, community-based research teams in each of the NGO that at the same time, with the help of the university, build the capacity of community members themselves to conduct research and to be paid as researchers themselves. With this created a whole kind of worms of how do we deal with ethical committees, how you able to pay people who use drugs to be able to conduct research, but in and of itself also remind us that harm reduction also in relationship with the university is not only a topic, but also has the capacity to reorganize and restructure through a lens of social justice the relationships that we establish between all the different stakeholders, and to take all of them as valid sources of knowledge, information, and skills. And what is also very important of this project, that I think is important also for academia university, is to take very much into consideration what you see in here. This is a magazine that was produced that was specifically targeting the communities of migration that we have in, which is like, how do we create content that at the same time has a repercussion directly into the communities? We are speaking that the student, like the study was really able to give us information about migration from 35 different countries of origin, which is a lot. And the second part that was important for us, it was to activate actually the academic centers in the universities to be really able to create within the journals, not only dissemination of information, but to call for action and to create advocacy purposes. So I'll leave it here, just with a bit of a summary. Things that are popping and cutting across, at least through our perspective, more through communities and service providers. If we will be imagining what is a curriculum for harm reduction, it will have for sure foundational harm reduction courses, including introduction to the history, principles, key concepts. Xavier has been speaking about that really beautiful. The importance of interdisciplinary perspectives, mixing epidemiology, social and health intervention, social impact. The thing that we are seeing at the moment a lot in the field is the need to be trained on intersectional approaches, not only gender-specific issues, but also racial disparities, migration, poverty, socioeconomic status. The practical application is very important, including community-based and community-led participatory approaches, as well as program design and evaluation. And last, the need for advanced and specialized topics. That has to do actually with including new drug markets and patterns of substance use. In Europe at the moment, we are having a big change. We are moving a lot into stimulants and smoking, which requires a very different type of harm reduction than the one that you have to be doing for injecting. We are looking into a different type of toxic market that is starting to happen in the north with netizens. So this requires different elements and specific things. Also very important for us, novel harm reduction strategies and technological approaches to social and healthcare and future trends. So I'll leave it here. Maybe we can have a chat later about this.
Thank you very much, Roberto. And now it's a moment of Professor Jallal Toufiq. Do you need the
Find my way.
to
Clicker? No, it's fine.
okay.
Yeah, I have to with the.
Okay, can I help you? Okay, here. What is your presentation? Is this one? This one? Okay. Okay.
Good.
That's perfect.
All right. Okay. Good afternoon, everyone. I'd like to thank the ISUDDR and ISAF for having me to present today on this very hot topic in this very hot city, but with warm people, right? Very warm people. I'm a psychiatrist. I come from Morocco, based in Rabat, and I'm currently the president of the International Narcotics Control Board in Vienna, but also a board member of the ISUDDR. This is the city where I live. It's called Rabat. It's the capital city of Morocco, where centuries of tradition actually meet modernity, and it's a very nice city, so welcome whenever you want. These are the main points I'm going to go through and touch upon, if you allow me, and I'm going to be speaking slowly because I know that the interpreters are a little bit annoyed. By all of us, don't worry, just all of us. I'm not pointing out to you, but just all of us. Over half a century ago, in adopting the 1961 Single Convention on Narcotic Drugs and also the 1971 Convention on Psychotropic Substances, the international community made a commitment to ensure and not restrict the availability of drugs considered being indispensable for medical and scientific purposes. And especially in the 1961 Convention, what we call the 1961 Single Convention on Narcotic Drugs, it highlights two mutually reinforcing goals. The first one is to ensure adequate availability of narcotic drugs for medical and scientific purposes. Remember, Article 4C, 1961 Convention. But at the same time, prevent the possible diversion and abuse. And that's exactly the issue we'll touch upon in this presentation regarding opioids. What's the role of the ICB? The ICB has in the convention some very specific mandates. It monitors and promotes compliance with the international drug control treaties. That's its first function. Works towards ensuring the availability of controlled substances for medical and scientific purposes. And it monitors availability. That's important. Availability, cultivation, production, import, export, consumption of controlled substances. So, to assist countries in knowing exactly what their needs are in controlled substances, INCB and WHO provide some guidance on how to properly estimate those needs. There are three methods that are used most of the time. The first one is the previous consumption, the last 2 years consumption. The second one is the needs for health services, and that's a tricky one. Not all the countries actually provide this. And the third one is the needs related to evidence of health problems, what we call the morbidity estimates. So, and by the way, it is possible to use more than one method in order to have a better estimate of the needs. The reality is that 75% of the countries use the easiest path, which is the past consumption method, and only 25% use service or morbidity. Thus, the estimates submitted to the board are based on the limited indicator of past consumption. This is the big problem that impacts mainly the availability of opioid analgesics globally, and that brings me to the topic of access, not excess. So let's start with excess, and I'm going to be very fast because I don't want to dwell on it because that's not the topic of today. I really want to talk about access because I think that's the most important thing. You all know what's going on in the world in terms of excessive use of opioids. So many factors that you all know. Longevity and autonomy, cultural issues about longevity and autonomy. The cultural issue about perception of pain, the notion of essential medicine versus comfort medicine, the idea also of we're entitled to it to the best of it right now, the idea of the right not to feel pain, any of it. I mean, these are things that are factors that are cultural and societal that you can find, and how can I feel not only well, but how can I feel better? Also the perception that doctors are relief prescribers. That's in many high-income countries. The problem of access to medication, and of course when it's difficult, what are the illicit channels of obtaining the same medications, what we call the options of replacement. And you all know people go into the streets to buy opiates to handle the pain problem, or chronic pain, when they don't have access to pain medications. Also the management of chronic pain, which is a big problem in our world nowadays. How the prescription of chronic pain is managed and how is it mastered in many countries. There's also this human rights dimension to it, that I have the right to treat myself and with whatever medication I want. So it's very complicated, but this is not the topic of today. So access. Access is a tricky one. Since the publication of the INCB's document, or first report on availability of controlled substances for medical purposes back in 1989, correct me if I'm right, I think it's 1999, together with its partners, INCB has continuously called for more attention to ensuring availability of and access to medicines containing controlled substances. So, several decades of data shows that there has been an increase in the reported consumption of opioid analgesics, but the gap between high and low and middle income countries remains very, very high. Also, we have seen an increase in the use of synthetic opioids, particularly in high income countries, but affordable morphine consumption has not increased as needed in low and middle income countries. Even worse, most of the morphine produced globally is not even utilized for palliative care. And the small portion that is used for palliative care is, again, consumed mostly in developed countries. Let me show you this analysis of the consumption of opioid analgesics as reported by governments to the board. It shows a persistent unequal access to and affordability of opioid analgesics such as morphine. A significant portion of the morphine produced worldwide is utilized for other purposes. Between 2001 and 2020, on average, 9.46%. It's this one. It's okay. 9.4%. Is it this one, right?
This one.
Yeah.
Okay.
Okay.
This one.
Yeah. 9.46% of the morphine available globally, I'm talking about the quantities manufactured and opening stocks, was consumed directly, primarily for palliative care. Only 9.46% for palliative care. And of that 9.46%, only a fraction, only 13.9% of that 9.4% was made available to a large portion of the global population, which is 80% of the global population, primarily residing in low and middle income countries. So it's really a small portion. The consumption of morphine, along with other opioid analgesics, remains concentrated in developed countries in Europe and North America. And levels of consumption in other regions, as you see, remain insufficient to adequately address the medical needs of their population. Another cause of concern is the continued decline in morphine production in 2022 that trend that started back in 2015. Let me illustrate also the data presented earlier in a more complete manner. And you can see that the manufacture of morphine in 2022 was over 218 tons. The total quantity utilized for consumption was even more, 257 tons, because you add, of course, the stocks. Of this, 94% was used to produce codeine. That then is used mostly for cough syrups. So only 33 tons were consumed directly for palliative care, but over 28 tons, that's 86%, were consumed by the US, the UK, Austria, and Canada. All high-income countries. Low-income countries, all of them, were left with only 129 kilos. 129 kilos for all developing countries, out of 257 tons. Let me also give you a long-term perspective. This was a reported average consumption to ICB in the years 1998 and 2000. Of course, red indicates high-level consumption that's over what we call 10,000 daily dose per million inhabitants, what we call SDDDs. It was only in the US at the time. The various shades of green indicated countries with daily dose from over 200 light green to over 1,000, that's green, and 2,000 darker green. This, in the estimation of the ICB, are really appropriate level consumptions. You see, my country at the time was adequately, providing for the needs of the population. The purple countries are those below 200 daily dose, dark purple, below 100 light purple. These levels are considered by the ICB as inadequate or very inadequate. A decade after, the situation became worse, of course, in North America and Europe, with countries reporting high level of consumption of opioids. And there was some improvement in South America, but the imbalance between regions remained very clear. You can see it. And you see, in my country, it went down when the consumption in North America went up. In my country, it went down because of the perception of prescribing opioids. In the period 2018-2020, there was a clearer indication that some countries are improving their level of consumption, while overconsumption in North America, Western Europe, and Australia persists, of course, as you all know. And if you look closely to Africa, because that's, of course, my continent, we can see a gradual improvement in the reported consumption, but still below what would be needed. The situation is also as worse as in South Asia and Southeast Asia. These are the main regions where there's a huge gap in access to opioids for care and pain management. This is a funny one because you see the size is, of course, proportionate to the consumption. So, and you see the imbalance in the availability of opioid analgesics for consumption through the expansion or reduction of the size of the each region. And you can see, for example, those countries, oversized are those where the consumption is really important, and those with shrinking sizes. You see, Africa is totally, even almost transparent. I mean, apart a little bit from North Africa, and also Latin America and Southeast Asia. So you see, that gives you an idea about the big gap between the regions in the world. If we compare the level consumption of the various opioids in daily doses, it is clear that fentanyl, of course, and now, of course, other synthetic opioids like nitazene, because of its potency, is responsible for large part of the increase in the last years, an increase that seems to have tapered off after some high consumption countries like the US and Canada introduced some restrictions in the medical use. And you can see a little decrease here starting 2018. Well, below fentanyl, further below, you may be able to see oxycodone in red and morphine in green. Oxycodone consumption has been increasing, but still slowly in comparison with fentanyl. Morphine consumption has been slowly decreasing. And that's, to me, the major problem. It's really morphine being decreasing, or morphine is the cheapest medication you can get for people who need it for pain management. and still it's decreasing. If you look again at the regional trends, we can appreciate again the gap in access between North America, West and Central Europe, and Oceania, mostly Australia, of course, with the rest of the regions that are really flattened against the bottom of the graph here. Shows you really the big gap. With the semi-logarithmic, we can show all regions at once, and you see South Asia and Africa are at the lowest level below 100 SDDs, with Central America and the Caribbean and East and Southeast Asia below 200 SDDs. In this graph, you can see the share of the various opioids by regions. Apart from the specific case of hydrocodone, of course, that's limited to the US, fentanyl is the major opioid in terms of daily dose in many regions. So, and also apart from analyzing the data on consumption, INCB has looked at what were the reasons for the lack of access to controlled medicines. So over several years, we asked competent national authorities, those who actually filled the forms and report the data, to indicate the main impediments and the main obstacles. And I just highlight that problems in sourcing and lack of training are reported to be the main obstacles mentioned in the last survey, while over the years, there is a strong decline in the mention of fear of addiction as an obstacle, and that was the case before. So it seems that more authorities now are gradually recognizing the more practical and concrete obstacles, and this is a good thing, of course, if we want to fix things up. The INCB also contributed to the development of the ONGAS 2016 outcome document that for the first time had a section devoted fully to availability and access to controlled substances with a number of operational recommendations, and let me share with you some of them. First of all is to encourage and support national and or regional production of pharmaceuticals to improve access and affordability with the cooperation with the pharmaceutical industry. That's what some African countries are starting to do, and Morocco is one of them. We start to produce our own pain medications that are under control. Consider banning the advertising of controlled substances and the international control. Train health professionals on palliative care. I think this is a very important thing. And we did a survey for a medical thesis on the obstacles to prescribe opioids for pain management. And we did it with the Moroccan Federation on palliative care and pain. And it's unbelievable how we saw the shift between, let's say, a decade ago and now, where physicians actually are now really being reluctant to prescribe opioids for pain management, which in my country, that was something really very, very common to do, to prescribe. I'm talking about, of course, acute pain, not chronic pain. And we're seeing also something that deals with the very fear of prescribing for chronic pain and a mishandling of that prescription for chronic pain and not always following the protocol for chronic pain management, which is something that's very tricky when it comes to not induce abuse and addiction. We also encourage countries to facilitate import and export authorizations. INCB has a very nice platform. It's called I2ES that allows countries to actually share information and also facilitate the import and export of internationally controlled medicines, like, of course, opioids. Among the other recommendations, I'm going to finish here, the INCB also recommends that more healthcare professionals be able to prescribe, not only health medical professionals, but also other, well, highly qualified, of course, health professionals. For that to happen properly, there is a need to train health professionals in the use of and rational prescribing of controlled substances to ensure prescriptions that are appropriate to the needs of patients. The governments also should mitigate the legal sanctions applicable in the case of unintentional errors because they limit the ability of health professionals to prescribe, and we see it in many countries where actually doctors are really just reluctant to prescribe because of the legal consequences. The ICB also encourages governments to increase the availability of low-cost palliative care services to patients. And also public health policy should prioritize the issuing of licenses for the manufacture, import, and export of essential medicines. And these are the main recommendations that were made by the ICB, especially to promote access to opioids for those who need them, mainly in developing countries. And I strongly believe that's one of the human rights of people. So thank you very much.
So thank you very much for all my colleagues. So we have some minutes if you want to ask something or to give your opinion about one of the topics that we talk about. I can, don't worry. Some questions? Okay.
Waiting for the room to warm up. I have one. I think it's it has to do with what is the best way to link the knowledge that's produced university-based and the skills that are important for those involved in civil society. How to link those. It's very easy to do it in developed countries, but it's very difficult to do it in developing countries where there's a huge gap between those who decide where the money goes, that's mainly policymakers, those who have the knowledge, mainly sitting, behind their desks, and those who work on the ground and in the field, and these are civil society professionals. So how do you think, what's the best way to make those people, work together? In developing countries.
It's a different ball.
Absolutely different.
Okay, I'll do the simple answer, although it's a bit more complicated. And I think I chose these three examples because in and of themselves are already putting forward possibilities that maybe it is not necessarily within the space of civil society, within the space of academia, or within the space of policymaking. Maybe in this moment there is a need for designing and developing other type of publicness in which people can take a tiny bit out of their zone and they can come and exchange. And I think it's almost like, when at least it's this game of words that sometimes pop into my mind. What I'm thinking of this is in public health is about creating a new healthy publics in which this relationship can be rebalanced. So these sort of like programs that take place, that they are topical works, I think a lot of that, for example, from Xavier program, of things that happen is include a lot of professionals, bring them into the field as much as possible, traineeships, placements, understanding what is the reality, understanding what is the ground. The other way around, universities involving as much as possible in this particular case. For example, you know both. You know the ground and then you're involved in a university. And also like trying to understand that this difference sometimes is much more subtle. There is a lot of people in civil society that have a fit in academia. In academia, there are sort of people with particular life experiences. So for me, it's a bit more about that subtle differences and similarities, recomposing them. That's why I say it's a bit difficult. Yeah.
So we could have time for one question. Michel. It's a long way. Don't worry.
Thank you. Jallal, I have a question on you. Thank you so much for such a complex point of view, and I think that it's pretty important to speak about something like that. Exactly, this is the right place. It was really clear that probably in core of this problem is attitudes and knowledge on the side of medical doctors. And it's obviously clear that what is happening now in the US as a reaction on opioid crisis, I mean broader discussion and reflection how bad is medical curricula, undergraduate, or graduate and postgraduate, and despite the fact how many years we have activities like ISAM curricula and international certification and things like that. By the way, we made very short survey in Central Europe, how many hours are dedicated on medical schools to addictions, specifically to addictions. By the way, the average number is 8 hours in 6 years. So that's, and I think that it's probably a very similar situation in other European universities. By the way, again, despite the fact that we have a European curricula for medical schools on addictions for 25 years. I don't know exactly how many years. So I think, and this is my question to you, is it something what we can do more in terms on pushing, and I know how sensitive it is, pushing on deans and staff of medical faculties an open discussion that it's absolutely out of reality, that it's not touching the reality, to have a okay, it works again. Sorry if I touch something. To push on medical faculties and medical staff to change something. On the other hand, it can be what is happening in the US, I mean, inviting deans, inviting deans and speaking with deans about this problem, and I don't know what we can do more. Maybe you have some more ideas, because, you know, I don't know if there is some reserve in communication with medical faculties and postgraduate institutes in education and training for medical doctors, because it's so frustrated how clear it is and how simple it is, but no response, and sorry for some pessimistic.
You know, Michel, what worries me is not the countries who have the means to tackle their problems. What worries me is the countries who don't. What worries me is a country like Africa. I come from Africa. I don't come from the US or Canada. I come from countries who don't have the means to tackle their problems. So for that, we need to think not only out of the box, but also go beyond the medical doctors. You don't need to be a medical doctor to prescribe, but you need to be well-trained to prescribe. You know, in countries, for example, in countries in Africa, we have 2 or 3, not even, people qualified in pain management. When in Africa, there are countries, and I don't want to mention them, but I have 2 where there is absolutely nothing done in the field of drug use. Nothing, 0. No action plan, no strategic plan, not even thinking of doing it. So I'm an African, and I want my country to maybe go beyond. So what worries me is that we stick to certain things that are, you know, well designed for developed countries. I want to think for something that could be well designed for countries where nothing is happening, and because people are suffering from pain every single day, and they don't have access to pain medications. And those who have access, miraculously, they may end up having a condition-induced addiction that cannot be taken into consideration, not recognized, and not treated. It's a tricky one, but one of the recommendations, Michel, I mentioned, is to go beyond medical doctors and train also nurses and other health professionals that maybe not necessarily medical doctors to prescribe medications. And you rightly pointed to the fact that what happened in the US impacted actually what's happening in Africa. And you can see on 2 slides, as soon as the US are starting to restrict access and the pandemic started, the perception of that pandemic actually had a huge negative impact on the prescribing attitudes and behaviors in our medical profession in developing countries. because they would tell to themselves, well, you know what, if this is happening in the US, it could happen in my country. But the reality is totally different. And so you have people left behind when you think like that. And culturally speaking, people don't have the same also perception of pain and also the debt management or near debt management. They don't have the same perception of being dependent on others, the autonomy, the longevity, being performant at work. These are different cultural things, but that's another topic, I guess.
So thank you very much. We arrived to the end of our symposium. I would like to express another time my gratitude to the speakers, the organization, ICU DDR. Thank you very much, and see you around. Thank you. Okay.
Bueno.
Thank you, sir. Thank you, Mr. Chair.